one of our System of Care 101 trainings from this 8-part training series. There are 3 more trainings coming up in I think December and January. So take a look at our website to find out about those and register. Today's training is going to be on the behavioral health system, and Jen, Travis, and Ian will be presenting from Multnomah, Clackamas, and Washington counties. Just some housekeeping. We're being recorded today so that we can post this on our website for later viewing. Feel free to forward that to friends later and colleagues so they can get the info as well. Please stay muted throughout the training and put your questions in the chat, and then the folks who are providing the presentation will answer your questions either as they go or they'll get to them by the end. Just want to share a little bit about System of Care. So we are a regional cross-system collaboration of youth and families and system leaders who work collaboratively to improve services and supports available to children, youth, and families in our region by building a true system of care model in the Tri-County region. So we support multiple meetings each month to address barriers. This training series comes from a barrier that was submitted by a person working with children and families. So you also can submit a barrier by going to our website at systemofcare.net. There's also some really great training resources on there, and you can learn how to get involved. So thanks, Ian, Travis, and Jen, for coming, and thanks to all of the participants for joining us today. And I'll just pass it on to them.
Hi, everybody. I'm shared my screen here. Can people see that? So Brian asked us to come together and do a little tour of the behavioral health system in the Tri-County area today. So we've probably got about 30 minutes of content. We might run through it pretty quickly, but the content will be available. I think this has been recorded, right, Brian? And the content for this slideshow we can make available too. We kind of put it together as a resource guide a bit for you, and also just some basic common understanding about how behavioral health works in the metro area. I'm Ian May, a supervisor at Washington County Behavioral Health. I use he, him, his pronouns, and obviously you can see the rest of us and who we are. I'm starting just with some real basics about behavioral health. You know, one thing that happens in our field is names change a lot, and there's different terminology for things and different words, and it can be a little bit confusing. So behavioral health has been called mental health before. It's substance use disorders has been called addictions, or many different words. But in general, behavioral health is the term that's being used now for treatments that are ways of helping people with mental health or substance use disorders. Counseling is another term here, and that or other specialized psychotherapies really seek to help people change their thoughts, emotions, and perspectives on how they see situations. I'm having a hard time here with my screen, sorry. Medication, psychiatric meds, another thing that's often a component of behavioral health treatment. And it's really one tool that helps folks manage symptoms of their disorder, really to get to a point where they can effectively use other strategies to pursue their own personal recovery. We're really fortunate here in the metro area in terms of how to access care, particularly for Medicaid or Oregon Health Plan members. Commercial plans may operate things a bit differently in some circumstances, but really here, guardians can just call and self-refer. They're not required to have a doctor refer or have any kind of gatekeeper to accessing care. So they literally can just call up an agency and say, hey, my son or daughter needs some help, and schedule an appointment. That appointment then, youth also 15 and above can do that for themselves. And then the first step always is an assessment. An assessment is, they're referred to as behavioral health assessments, mental health assessments. They can be chemical dependency or substance use assessments, but assessment really is a key first step, and that has to occur before treatment can happen. It's a thorough social emotional history, and then this is where those disorders are diagnosed. So the clinician says, well, based on what I hear, your son or daughter or your student or this young person seems to have this diagnosis, and that then leads to specific treatment recommendations. And then they receive treatment for that, or offered treatment. Again, I haven't said this, but everything in the mental and behavioral health system is voluntary. So we don't do anything to people. We do them with people who voluntarily want to participate. So treatment is really a time-limited, targeted intervention that helps alleviate the behavioral symptoms. And they're really specific to that diagnosis and the level of care that has been recommended from that assessment. For us counties that are here, it's important to share that a lot of what we do is related to Oregon Health Plan members in the metro area. Strange. We've provided you guys some links. You can help young people apply for the Oregon Health Plan. It's important to share that youth involved with child welfare are most likely Oregon Health Plan members. For the rest of the community, there are income requirements for eligibility. In the local area, there are 2 coordinated care organizations now that members will be assigned to. It's either Trillium Community Health Plans or Health Share of Oregon. And for Health Share, Care Oregon manages the behavioral health benefit. Folks who've been working with us counties for a while have, this is a change. At the beginning of 2020, the counties shifted the responsibility for managing the behavioral health benefit over to the coordinated care organizations. Historically, the counties have managed that benefit. So if you have any questions about that, obviously chat them away. We thought it would be useful to share like how you can help a young person find a provider. One of the first steps is obviously what is their insurance? And that's a strange question to ask people, but it's really important. If they the insurance plans are the funders of behavioral health, and so they manage the networks and are the people to reach out to. So you can teach them how to schedule an intake with a provider. You can help them figure out how to find a provider online. There's the 2 network portals for Trillium and for Health Share right there. And you can also help them learn how to call their insurance to find a provider. It's calling your insurance plan is not something that most people naturally think of, right? You just go to the doctor, do what the doctor says, get referrals, go to the doctors. In behavioral health, especially for Medicaid, the CCOs are very, very involved with their members' care and want to hear from them and want to help. So we're going to do a quick tour of some of the services that are available. This Jen's going to do most of the tour guiding. I'm going to do a little brief snapshot. So these are some agencies you've probably heard of. These are some of the larger agencies. By no means, this is not a comprehensive list at all. There's many, many agencies, large and small, individual providers, kind of consortium of clinicians that are on the health plan panels.
Ian, there was
These
a
are some.
couple, sorry to interrupt. There was a couple questions
Oh,
in the
go.
chat about
Yeah.
commercial insurance. One being about referral process for children who have coverage through commercial insurance as well as OHP. And then another about folks who don't have any insurance and don't qualify for OHP. I wanted to acknowledge those questions. I'm not sure if we want to talk about that now or maybe kind of get back to that at the end.
Let's circle back to that one and to those two questions, if that's all right.
Great, thank you.
Yeah, of course. All right, so we also wanted to share some of the kind of levels of care that are available. This is not an exhaustive list, and I'm not going to go through in detail because this is available for you later, but some of the things you may have heard of level D or CBIT or organ intercept. These are all kind of escalating in intensity: psychiatric day treatment, partial hospitalization, psychiatric residential treatment, subacute, acute care. So acute care, that's like when a kid is imminently in severe danger and is in a hospital setting for a short time. There's also long-term hospital care. Some of you may have heard of the Farm Home or Perry Center. This is a hospital level of care that some children go to that have very severe mental illness. Eating disorder treatment, psychological testing, ABA, applied behavioral analysis for young people with autism, DBT, dialectical behavioral therapy. We're very fortunate to have them in our network. The reason I bring those up is because a lot of them, so while people can definitely access mental health treatment without a referral throughout the network and throughout our community, there are certain thresholds where as intensity goes up, where the health plans are required to make a determination whether it's medically necessary or not, whether it's medically appropriate. This slide gives a little snapshot of how those decisions are made. I also want to share that they're made using nationally vetted criteria sets, and the folks at the plans who are making the decisions have specialized training and certifications, and also do something called inter-rater reliability to make sure that whoever uses the systems, it's being used consistently across the decision makers. But when you have a diagnosis that's covered and there's a matching evidence-based intervention to that diagnosis, and there's reasonable expectation for improvement and less intensive treatment has not been successful, those are some of the ingredients that go into the decisions about medical necessity. I like using medical examples. So I think of, like, if you showed an x-ray of a broken bone to 10 doctors, and how likely would it be that they would all come up with the same appropriate intervention for that? Is it a splint? Is it a cast? Is it, cut them open and do surgery, insert bolts and so forth? That's kind of what medical necessity is about, is like, what is the appropriate treatment for what we're seeing clinically, and how do we get the best outcome? I think that's the end of my piece. Jen is going to continue our tour, and please keep the questions coming.
Thank you, Ian. As Ian mentioned, I'm Jen Evans. I'm the interim supervisor of wraparound in Multnomah County. And I am going to continue us on our tour of supports and services. And just again, as a reminder, these all can look a little bit different in each county, but this is really just a general overview of what's available across counties. And I also want to just give a side note that youth and families do have the right to have services that match their culture and the language that they speak. And they can request information about those supports and services through their CCO or through the behavioral health divisions as well. So just a little side note. The first thing I'll talk about is respite care. Respite care is provided in certified foster homes that focus on providing a safe and supportive place for youth coping with mental health disorders and who are at risk of out of home placement because of really the family's emotional distress related to managing those behaviors and those needs in the home. And while in respite, children and youth are often able to access fun, recreational activities, so that's important to know. They serve youth ages 3 through 17, and there is planned and crisis respite available depending on the youth's needs. Referrals do need to be made by the mental health clinician. Next. Thank you, Ian. So transitional aged youth, sometimes these services are also referred to as a YAT, young adults in transition. So like Ian said, the language is often changing in this field. But transition aged youth services is provided by a couple of programs across the Tri-Counties. One of them being Transitional Age Youth Intensive Services, which is for youth ages 16 to 24 during their transition to adulthood who have significant mental illnesses impacting their ability to really function in the community and achieve their life goals. So there's a combination of supports that can be provided to them. And then the other one is a program through LifeWorks, also called STRIDE. STRIDE stands for Strengthening Tools to Recovery, Independence, Determination, and Empowerment. And STRIDE is really a hub that connects young people ages 14 through 24 who are also struggling with mental illness to really identify their goals, connect them to community resources, and the ultimate goal being to overcome barriers and improve their well-being. This is again available across the Tri-County regardless of insurance status, but there is an emphasis on those experiencing houselessness, transitioning from foster care or residential treatment, and or those who identify as being part of the LGBTQ+ community. And next, ESA. This stands for Early Assessment and Support Alliance. This is for young adults ages 12 through 25 who are experiencing their first psychotic symptoms or symptoms consistent with psychosis risk syndrome. So it's a very specialized program. It's a 2-year transitional program that uses they call it a transdisciplinary team approach. So this includes therapy, psychiatry, nursing support, peer support, occupational therapy, and supported employment services. So really a combination of supports. There are specific criteria involved in their screening process, and the services are available regardless of insurance status as well. So going back to that question around what about youth who don't have OHP or other insurance, this is a program that would be available. The ESA supervisor in Multnomah County, just as a side note, Angela Peterjanis, is available to provide a full presentation about ESA if you're interested. And next. Substance use disorder. This is often referred to as SUD. Each CCO, so each coordinated care organization, offers a range of treatments for substance use disorder. And that really goes from office-based counseling all the way up to residential treatment where youth are staying in a facility to receive that treatment, and it's much more intensive. It's also important to note that outpatient services can sometimes be offered at the same time as mental health interventions at agencies where clinicians have both certifications. So in mental health and in SUD treatment, those clinicians are often referred to as dual diagnosis providers. And next, crisis and urgent supports. So there's a wide array of supports available for those who are experiencing crisis, at risk of harming themselves, others, or just struggling to function. And I'll give you a quick overview of some of them. They include crisis lines, urgent care walk-in clinics, crisis stabilization services, and emergency departments. For the county crisis lines, these are free 24/7 call lines that are available for mental health support. They are staffed by master level clinicians. These clinicians can dispatch the mobile crisis team or refer to the walk-in clinics or to 911 for in-person support. They can accommodate non-English speakers. They will utilize interpreters if necessary as well. And it's good to note that that it's totally okay to call before a crisis to get support, because they can help with referrals to low cost and sliding scale mental health and addiction services, and provide information about non-crisis community resources. So going back to that question about supports for people that are uninsured or underinsured, that is another resource. Mobile crisis response. This is access through the county crisis line 24/7. They provide in-person response, typically includes 2 clinicians for help resolving crises. It can be expedited for police and for fire if necessary. And some examples of places that they will respond to are residences, schools, social service agencies, businesses, and there's a lot of others. Really, it's just community-based in-person support. Next. Walk-in centers provide urgent care services for mental health and addictions concerns. These are clinics that are available to children and adults who need rapid care but don't necessarily require hospital-based help. Appointments are not required. This is a no-cost service. They can bill insurance if that's available. And this is a short-term service that can include assessment, help with stabilization, safety planning, referrals to community resources, and referrals to other providers for ongoing treatment and support. And in some instances, if appropriate, psychiatrists and psychiatric mental health nurse practitioners can provide medication, evaluation, and consultation. Next. These are just the 3 walk-in centers that we have across the Tri-County area. So Cascadia Walk-in Center, which is located in Multnomah County, Clackamas County Urgent Mental Health Walk-in Center in Clackamas, and the Hawthorne Walk-in Center in Washington County. Crisis stabilization services are brief home-based stabilization supports. By brief, we mean typically 4 to 8 weeks. That can just depend on the need. There are multiple contacts that providers are going to have with the youth and family throughout the week. And those are going to be focused on safety planning, really stabilizing symptoms, and connecting to longer-term ongoing mental health services. These can be accessed through any of the walk-in clinics or hospital emergency departments. And with that, I think I'm going to transition us over to Travis Tarpo with Clackamas County, who's going to talk about care coordination.
Awesome. Thank you, Jennifer. So yeah, I'm Travis from Clackamas County, like Jennifer said. I'm going to talk to you about some of the options that we have in the Tri-County area for care coordination. And the next slide will show 3 options that we have. And they are organized on this slide in terms of intensity of care coordination. Intensity doesn't mean better or worse, but simply just how many contacts and just kind of what the best fit is for the situation. So the first one here is provided by the CCO. So that would be telephonic care coordination that happens through the CCO. So like Ian was saying earlier, right now we have 2 CCO options. We have HealthShare and Trillium. Trillium is newer to our community, and so we are still learning a little bit about what their care coordination options look like, but I'll do my best to kind of touch on what we do know about their options and talk a bit about what we know for HealthShare. So care coordination through the CCO is going to be more of a short-term and kind of low intensity support. Intensive care coordination, or ICC, you might hear that acronym ICC. That's based out of the counties, and so each county has their own ICC program. And that's going to be telephonic, but also some in-person coordination. And these, the name kind of implies it, are for situations and clients that have more of a intensive need for coordination. And they'll have kind of a plan that they'll work with the client on as far as what the coordination is going to be about. And then the most intensive of the care coordination options is wraparound care coordination, and this is geared toward youth. And it's also based out of the county, so each county has their own wraparound program. And this is largely in person, although right now, like pretty much everybody, it's a lot of Zoom meetings and things like that. But without the coronavirus restrictions in place, it's very in person and kind of a long-term personable intervention. Next slide. So a little bit more about CARE, the CARE Oregon Regional Care Team. This is housed out of the CCO, which is HealthShare. And I saw a question in there about HealthShare and CARE Oregon and their relationship. And there's just kind of a umbrella of HealthShare. HealthShare is the CCO for one of the CCOs for HealthShare. And then under that is CARE Oregon that manages some people's physical health needs, but everybody in the Tri-Counties areas mental health. So they manage the mental health benefit. And so they have the regional care team, which is on the previous slide actually. And the regional care teams are experts from various mental health and physical health professions that are kind of sitting in the same area and work together as a team to problem solve care coordination needs as they come up. So it's a phone-based intervention. And you can see that you can make a referral directly to CARE Oregon. All right, next one is the intensive care coordination. Like I said, that's county-based. And it's telephone and in person. You can make referrals there through HealthShare, or you can make a referral to CARE Oregon, and you can see the information on the slide. For Trillium Community Health Plan members, referrals are made through that email address that you see there. And starting in 2021, Trillium will have their own ICC program in-house for themselves. So it will be separate from what the counties are doing. And the next slide. Wraparound, like I said, that is the most, I guess, intensive of the coordination supports. It tends to last anywhere from 9 months to maybe up to 1.5 years, really depending on the youth and families' needs. I would say a characteristic of wraparound is that it's a long-term support. It requires a lot of family, youth, and team participation with kind of monthly, at least monthly meetings. And what else was I going to say about it? I guess that's what I was going to say about it. You can see there the referrals, and they're made directly to the counties. And so those phone numbers will take you to the intake teams at each county. You can also go to HealthShare on their website there. You can see the link to find the forms that you can then send in for a referral. Oh, the other thing I was going to say about wraparound is it's specific to young people who have involvement in multiple child serving systems. So that would be someone that maybe has mental health involved, maybe has special education and is on an IEP, maybe involved with juvenile justice, DHS child welfare. So if there's 2 or more of those systems and there's kind of complex needs, wraparound might be a good fit. And you can certainly contact our intake folks for more information if you have a case that you're interested in. Next slide. Peer-delivered services. These have been some pretty cool supports both within the wraparound program, but there's also peer-delivered services that are kind of in-house in some of our provider programs. So we have a few different peer-delivered service agencies, Oregon Family Support Network, Youth Era, and there's a few others that work within the Tri-County area. And there's also some, like I said, within different agencies. I know Catholic Community Services has at least one peer-delivered support. And Peer-delivered services is really people that have had similar life experiences to clients that are in programs like Wraparound, who can come alongside those folks and help them through what they're working through. They're also really helpful in the SUD world, and there's a lot of peers that can be helpful through substance use disorder programs. Next slide. All right, this is a bit of an aside, but there is a really cool website called Get Trained to Help, and one of the coolest ways to impact our community in a positive way is to get trained to assist people who might be experiencing a mental health crisis. And so there's various trainings that are offered through this website. Question, Persuade, Refer, or QPR. Everything has a letter combination associated with it. Applied Suicide Intervention Skills, or ASSIST. Youth Mental Health First Aid, and then counseling on access to lethal means. So if you're interested in learning more about how to help others, you can check out this website. Next slide. All right, how to coordinate with us. If you have a client that you are working with, a young person or a family, you're going to want to get a release. You want their permission to reach out to someone like us about their situation. You can call or email a provider or care coordinator. Call your county behavioral health department, and so you can see those phone numbers there. You can call Trillium Community Health Plan at that number. And like Ian said earlier, it's important as you're assisting folks to ask early on what their health insurance situation is, and that will help you understand who you're going to be contacting. And you can also call Care Oregon at that number there. And I saw that someone answered the question already, but just to reiterate, Care Oregon is usually the first point of contact if you have questions about anything that has to do with services and supports in the Tri-County area. That's a good first point of contact rather than HealthShare. And that's, I think, it for my part there.
We've got lots of questions in the chat. Wonder if we should just roll through them and see if we can do our best to answer them. Does that sound okay, Travis, Jen?
Sounds good. I
can see the chat now that I've stopped sharing my screen, this darn Zoom stuff. What is the referral process for those children who have coverage through commercial insurance as well as OHP? So if a person has OHP secondary, the federal Medicaid rules and OARs require that the commercial insurance is the primary payer, and the Oregon Health Plan is the payer of last resort, or kind of a backup kind of safety net payer. So you would want to have them contact their commercial plan for access to any services. That OHP it can be there for post-adoption, so adopted kids. Some Native kids have Oregon Health Plan secondary, even if they have commercial insurance. And frankly, sometimes there's just wonky situations where it just happens that people have both. But usually when there's OHP secondary, it's going to not be enrolled with a coordinated care organization. It will be managed at the state, something that's referred to as open card. And so still the commercial is still the primary funder for any kind of services. What about people who don't have insurance and don't qualify for OHP or Medicaid?
Yeah, I'm going to put some resources from Multnomah County in the chat here that touch on a few of these questions. For Multnomah County, there is a Multnomah County Treatment Fund. That's a safety net program that helps pay for mental health treatment for people who are uninsured and have limited financial resources. So there's a link for that. I don't know about Clackamas and Washington County.
Washington County also has a general fund contracts with many agencies. So if you have that situation, just definitely reach out to your county behavioral health program. Can you explain the difference between Care Oregon and HealthShare and when families would contact each one with questions? I have some families feel they get caught in a loop between calling one and then they're told to call the other. So it's in the presentation somewhere. Care Oregon, so Care Oregon is managing all of the behavioral health for HealthShare, on behalf of HealthShare. So if it is related to behavioral health, mental health, addictions, that kind of stuff, call that, definitely call the Care Oregon 416-4100 number. Care Oregon has kind of tried to adopt a no wrong number policy, and you might support them in calling and, you know, call with them and, you know, continue to express what they're after until they get the answer that they need. That's my best answer. So Care Oregon contracts with, HealthShare contracts with Care Oregon to manage behavioral health benefits. So they manage the whole network of providers. They contract with all the providers and fund them and oversee the services they're providing. And then Care Oregon contracts with us 3 counties to do some of the specialized care coordination work. So intensive care coordination and wraparound. Does that help a little bit, maybe? I don't know. Hope so.
Brittany, feel free to chime in if you needed more clarification about that. I know it's confusing, the relationships between HealthShare, Care Oregon, and the counties.
What's level D? Tamara, Tamara Bakewell. Level D is a level, an intensity level of outpatient treatment, community-based treatment. It is, many agencies provide that level of care. So it is, with COVID not around, it is home, you know, primarily community-based. So in people's houses, in their schools, in their, wherever they are, it's multiple contacts per week. It's supposed to include skills training. So skills trainers to augment the therapy that's taking place. It has crisis response embedded in that level of care. So it's one of the highest, you know, community-based levels of care that that there are.
And I would add that the combination of supports between individual therapy, family therapy, skills training, all depends on each youth and family situation. There may be more skills training than therapy, there may be more therapy than skills training, mainly individualized therapy for the youth and family therapy. So it's really tailored to what they need. But the idea is that typically community-based, multiple contacts per week.
Brian Whitmer, I find that most of my questions get answered by Care Oregon, so I go there first. Oh, that was probably an answer to a previous question.
The next one is also an answer to a previous question, just regarding level D.
All right, Catherine. I haven't made a mental health respite referral in over 2 years, but has the waitlist/provider situation improved? It used to be just Morrison with an extensive waitlist. There is more than Morrison doing respite at this point. I think what trumps everything is that the coronavirus has really impacted that service quite a bit. But I don't think I have heard of really extensive wait lists like that. It's not a super easy thing to get rolling, but what we've seen in, at least in wraparound, is that once a respite provider and the relationship is established, it can be an ongoing service that the family can utilize.
That's been my experience in wraparound as well. I think it can be challenging to get that service up and running, like Ian said, but I think it is worth the referral, because I have seen even in the coronavirus restrictions that Morrison's been able to connect families with respite. So it could be worth a referral.
The next question is whether respite can be overnight as well as day respite. Absolutely. I've seen families use it for just a few hours or a couple of days. So it really does vary.
I don't know if it's just me not hearing Jen.
Was I too quiet? Can you hear me if I'm a little louder?
Yes, I think it's your mic. If you're a little too quiet, it kind of cuts you off.
I'll scoot closer to it. I don't know if you caught what I said, but I said respite is overnight and just for the day if needed. Again, it's one of those supports that can really be tailored to what the need is. I've had families that just needed it for part of the day to get a break and weren't comfortable with overnight respite, and then families who use it for a couple of nights or more. So,
Alice, where does St. Mary's Home for Boys fall into this all? I'll take that because they're in Washington County. So St. Mary's is a BRS program, Behavioral Rehabilitation Services Program, so the young people that live there it's paid for either by child welfare because they have access to BRS placements, or by the Oregon Youth Authority. They also have access to BRS placements. So for a child to live there, one of those agencies has to be involved. However, they also have outpatient treatment, which so they're a contracted outpatient treatment provider. They also do respite for us in Washington County for young boys, not super young, but I think 11 and up at times. And then they are also have a educational day treatment program there. It's not a mental health funded day treatment, but several of the school districts in Washington County use it as a day treatment.
I think Ian froze. There you are.
Ian, your screen froze for a minute there, and we missed the last thing that you said, I believe.
The thing about day treatment?
Yeah, you were telling us about day treatment, that it's accessed by the schools in the area, and then I think we missed the rest.
Yeah, that was about it, probably. Several school districts contract with them for their special ed for some special ed day treatment slots. Sorry, I got a little thing that said my internet connection is unstable. I do have 5 people on the internet at this house right now, so that wire is hot. SUD treatment available for those under 18 ? Absolutely, yes. And so there's another, I don't know if it was in one of the slides, but sometimes SUD treatment happens within mental health agencies by sometimes the same clinician, often ideally. They call them dual diagnosis clinicians. So they're dual credentialed in SUD work and mental health. But there's also just specific SUD treatment for kids under 18, all the way up to residential treatment.
And I put a link for Multnomah County in the chat box where you can find more info about youth SUD treatment. It's also something you can search through the CCO provider search engines. I think there's some links to that in the slides.
You can also call the county behavioral health because all of our counties have SUD, not providers, but programs and expertise for sure. All right, Michael asks, my recent experience with students who are served by IEPs is that insurance would greatly prefer that we, the school sped service providers, offer a higher level of service at school before they do. Even if there's a significant global issue, it seems as of late that students are unable to meet criteria for day treatment as seen by the insurance company. As a result, students suffer and they present with chronic, at times dangerous symptoms related to their mental health. Trying to fish the question out of there. It's that's a horrible experience that you've related. I guess, you know, if a student is involved in mental health and on an IEP and you're struggling to access care for that student, I'd say first strategize with the provider that's doing the mental health treatment, because ultimately referrals for those higher levels of care are going to need to come through them. And probably simultaneously reach out to your county behavioral health to get support. The student might qualify for intensive care coordination with the county. They might be a good candidate for wraparound. Either one of them can really help kind of not grease the wheels, but, you know, help ensure that that individual gets an adequate level of mental health care.
The other thing I would add is that if this is more systemic, so across CCOs and you're seeing this kind of as more of a systemic issue than with one insurance, I think it would make sense to maybe submit a system barrier form around it, around access to day treatment or whatever types of supports. I did put a link in the chat box with a to the System of Care website that has a barrier submission form. So any barriers that children and families are experiencing within behavioral health that are systemic can be put there. And then we have groups that really look at those barriers and brainstorm and come up with action steps to address them, just as a side note to that.
Another question, are all of those crisis services applicable for pediatric patients as well? When you say care coordination provided by the CCO, do you mean the regular customer service line of the CCO? So the customer service line of the CCO, you can't see the PowerPoint, I'm looking at it still. Both of those are just access points to get into the CCO. For Care Oregon, they have a couple of different actual sets of care coordination teams in-house. So they have a pediatric team, and each county has a regional care team. So it's different than regular customer service for sure. At Care Oregon, those teams have like multidisciplinary across the health fields folks on each of those teams. The members can be assigned individual care coordinators that work specifically on their situation with them. Trillium is going to have intensive care coordination in-house starting in 2021, both for mental health and substance abuse disorders. And yes, it's all available definitely to young people under 18. And I wonder if by pediatric patients you mean even younger kids, but yes, I see intensive care coordination is available to all members with complex needs through the CCOs, yes.
Wraparound is as well, birth through 17 and up once they're in the program.
Do providers need to figure out whether to submit a referral to ICC or wraparound? How and when would you refer to ICC instead? Do providers need to figure out whether to submit a referral to ICC or wraparound?
That's a really great question. I think the really nice thing right now, can you still hear me okay? Or am I cutting off?
Cutting off just a little bit. We can hear you mostly.
Okay. I think the nice thing right now is that when you submit a care coordination referral to Care Oregon, there is a screening process there in which they'll look at, is a regional care team, that telephonic care coordination support, enough to meet that need, or does it need to go to an ICC? So if you send a referral for care coordination to Care Oregon, it's going to land where it needs to. The wraparound referrals do go directly to the wraparound programs, but those wraparound programs are really closely tied to the ICC programs as well. So whenever we get referrals, we're always looking at, is this a better fit for ICC or is this a better fit for wraparound, and discussing those options with the families if needed. So I don't think you need to overthink about where it goes. We're going to help it land where it needs to land. And Travis and Ian, please chime in if that doesn't seem accurate, but that is my experience within Multnomah County.
I think that's the experience in Clackamas as well. I know once all of the care coordination programs know of each other and know of the kind of qualities of each program. And so sometimes a young person might start out at the CCO level, and then it becomes clear to that coordinator that the needs could be better served through ICC or RAP, and then vice versa. So I think, like Jennifer said, not stressing out about, okay, I don't know which one is the right one. I think contacting Care Oregon, or even contacting the county if you think wraparound is appropriate, is a good first step. And then the people on the other end of the line are going to help you figure out what the best first step is going to be.
Same for Washington County. Call us. I'd rather you call me or call anyone here at our program and let us help you through it before you spend any effort and time, filling out something wrong or doing something, wasting your time. Give us a call. We'll help you think it through. Is there a specific pediatric team? I wish Tamara could talk, because I'm not sure what you mean by that, by pediatric team. But can families self-refer to wraparound? Yes, they can. And families often come to the screenings themselves, youth as well. There isn't a determination for medical necessity, but there are some requirements in the Oregon administrative rules related to how wraparound referrals are processed. So the counties don't actually decide who gets into wraparound or not. Each county has its own wraparound review committee, which is made up of all of the child serving system partners. The counties collect the information and make sure the right stuff is there to meet the rule, and then participate in the WRAP review committee where the determination is made whether to enroll the youth or make other recommendations. For wraparound, there isn't a I don't know, by pediatric team, I'm thinking you mean like little kids, like smalls. We do work with kids of any age. There's actually a different criteria regionally for early childhood kids, so children that are ages 5 and below. But each of our teams, I think, have definitely have team members who their passion more aligns with the younger population, their expertise more aligns with early childhood. So that's my answer. Liz Hawk, could you share the list of providers for the respite care services Jennifer mentioned?
I can pull Morrison's if there are other ones. I don't know, Travis and Ian, if you have them handy.
The only one, but I think it's just for kids that are being served at Catholic Community Services. I think they may have a home or two, but that would be for youth that are already in their intensive services. I can't think of another. I know that my supervisor is on the call here, and so I'm going to look at the chat, and I'm sure he'll put something in the chat if there's more to add to that from Clackamas.
And the other one I mentioned is out in Washington County. We do use St. Mary's does some respite for us, as well as the Morrison.
As a side note, there is sometimes respite support available for youth who have DD services, so intellectual developmental disabilities.
It looks like we made it through most of the questions. Any other burning questions people have? I guess this is going to get posted or something, Brian, on the System of Care website. Is that right?
That's right. We'll have the video up for viewing probably next week.
I hope this was helpful. I gotta say, I really appreciate the executive committee putting these things together. As I was thinking about doing this talk today, I was like, man, I remember I worked in so many different areas and starting to do this work in the mid 90s. I feel like it took me like a decade to kind of even understand how all these different people interfacing with young people, like what their roles were, how they interfaced, how to work with them. So hope this is a small help to help everyone get doing their best work as quick as possible.
Thanks, Ian and Travis and Jen, for presenting today and for your insightful answers. And it's really appreciated that you volunteered your time on top of your busy work schedules to provide your expertise. And I really just wanted to thank you on behalf of the whole System of Care.
I would like to thank my family on behalf of the whole System of Care, because it is a miracle that during lunchtime there was no yelling going on or anything. So thank you,
Yeah.
children.
A yell-free training is a good training. All right, everybody. Thanks so much, and we'll see you around.
Thank you.
Thank you. Bye.
Bye-bye.
Thank you.